Welcome, everyone. I'm Dr. Carmen Pugliafito, and here today on Retina Synthesis, we have once again Dr. Phil Rosenfeld from Bascom Palmer Eye Institute. Phil, welcome back to Retina
Oh,
Synthesis.
Carmen, thank you for the invitation. It's always a pleasure to chat with you.
You've been involved with some fascinating work that was recently published in the neurointerventional radiology literature looking at ophthalmic angioplasty, artery angioplasty for geographic atrophy. Where does this all come from?
Well, Carmen, it may come as a surprise, but this concept has been brewing for over 30 years. I remember when I was a resident at the Massachusetts Eye and Ear Infirmary, and Ephraim Friedman, who was then president of the Mass Eye and Ear, had this idea that AMD was caused or exacerbated by decreased perfusion to the eye. And he had this concept of scleral rigidity, decreasing the amount of blood that can get into the eye. And I remember him talking about it when I was a resident. I really didn't grasp what he was implying by this lack of blood getting to the eye. But I know he tried to thin out the sclera, but he didn't have much success. And the idea kind of died, even though he wrote a perspective in the AJO, kind of outlining his rationale for why decreased perfusion may contribute to AMD. And the idea kind of lay dormant for about 20 years. And I was contacted by a group called Ocudyne to pursue this concept, but they were originally interested in it because of their relationship with Judah Folkman, and they were interested in wet macular degeneration. But the concept has taken on a whole new meaning after reviewing 20 years of research in the area of choroidal perfusion. And I'm pleased to say that a lot of our work, in which we investigated swept source OCT and the choroid, have contributed to where we are now.
So tell us a little bit about the preliminary work which was done in Buenos Aires, Argentina.
What I want to do is kind of back up a little bit
Okay.
and go back 10 years ago, probably 12 years ago now, when Jeff Franco reached out to me. He's the CEO of a company called Ocudyne. And he's always been interested in this field. He's an entrepreneurial, serial entrepreneur, mainly in the field of cardiology. But he always thought that it was pretty obvious that wet macular degeneration is a disease of ischemia, leading to a hypoxia, lack of blood flow, leading to oxygen deprivation. And this is where the Judah Folkman angle came. I mean, he actually started a company with Judah Folkman that failed. But his idea was, wait a second, VEGF is being produced. VEGF is an ischemia-related cytokine. Why isn't anyone looking at the cause of VEGF production? We always focus on getting rid of the VEGF after it's produced, but no one's really interested in stopping the VEGF from being produced at its source. So to him, it was intuitively obvious that there's a perfusion problem, and that's why there's ischemia leading to hypoxia. So he pursued it from that angle, but then we kind of stepped back and took a more global perspective of AMD and started pulling together all the pieces of evidence to suggest that there's a perfusion problem. Because as you know, Carmen, AMD is a late onset genetic disease, and there are environmental factors. And we know the genetic candidates that contribute to AMD later in life. Man, we talk about the environmental factors, but we give it some lip service. We don't really pursue it other than, well, you better not smoke, and you better eat a healthy diet, eat your dark green leafy vegetables, and take your AREDS vitamins. But no one talks about the cardiovascular risks and the obesity risks and the association with decreased perfusion to the heart and the role that that may have in AMD. What's interesting, Carmen, if you think back to the Framingham study and all the big epidemiological studies like the the Rotterdam study, the oh, I'm blanking now. Sorry. You can slice and dice this, right?
Yes.
Yeah. So, okay. So if you think back to all the large epidemiological studies like the Beaver Dam study and the Blue Mountain study and the Rotterdam study, um, you would think that there's a strong association between cardiovascular risk factors and AMD, but actually it's kind of weak. It's a very poor association from all those studies. Where the real association occurs is in high risk cardiovascular disease, not the generalized cardiovascular disease, but the high risk cardiovascular disease that really decreases cardiac output and perfusion to the eye. And I have to credit Ted Smith here, who's been talking about high risk cardiovascular disease and reticular pseudogenism for many years. And he's right that there's a strong association between these high risk cardiovascular disease, diseases that decrease cardiac output, in particular, cardiac output to the brain and the eye. And he's associated these reticular pseudodrusen with high risk cardiovascular diseases. And as we all know as clinicians, these reticular pseudodrusen are associated with a thinning of the choroid. They're associated with type 3 macular neovascularization, which is the neovascularization in the retina. And then we treat it with anti-VEGF, and lo and behold, once we suppress the neovascularization, you get atrophy, rapidly progressive atrophy, shortly after anti-VEGF therapy. So there seemed to be this association with perfusion and atrophy. And then along comes our studies looking at choroidal thickness. With age, your choroid gets thinner and thinner and thinner. And AMD, that thinning is actually accelerated. And people think initially, since we're retina specialists, we think all things in the eye drive the disease process. We think, well, the AMD must be thinning the choroid. Well, what's an interesting concept, but what's the mechanism whereby the disease in the macula causes choroidal thinning? And then we showed that just with normal aging, you lose your choriocapillaris in the central macula. Now, this was shown histopathologically. So just in normal aging, think about it. Your choroid's getting thinner. You're losing your choriocapillaris. This isn't the eye driving the decreased perfusion. This is the decreased perfusion occurring with normal aging. Oh, and if you happen to carry the genetic at-risk alleles, it's like throwing gasoline on a fire. I have to also give Hayray credit. You know, those of us who were in my generation knew of Sohen Hayray as the father of ocular and orbital vasculature. He did all of this in the 60s and 70s, and he actually identified back in 1975 that the macular region is an area vulnerable to chronic ischemic disorders. And he came to this conclusion because he rationalized it when he followed the short temporal posterior ciliary arteries that arise from the ophthalmic artery. He saw that there's this watershed area in the distribution of these short posterior ciliary arteries under the macula. Well, now that's one possible explanation is you get older, you lose macular choriocapillaris perfusion, and lo and behold, the submacular region is the area that's most at risk for these perfusion defects as people develop macular degeneration. So you've got the Hayray results, you've got the Ephraim Friedman observations initially, you've got our studies looking at just normal perfusion abnormalities with aging, and those perfusion abnormalities occur mainly in the submacular region. And then along comes Occudine, and they did this cadaver study in Minnesota they had these heads, these AMD heads that they dissected, and they found that there were these stenoses at the ostium of the ophthalmic artery, where the ophthalmic artery comes off the internal carotid. You may remember from your anatomy that the internal carotid artery, the first intracerebral branch, is the ophthalmic artery. And he found stenosis at that ostium. And he proposed, gosh, this was way back in 1962. And again, he wrote a review in 2016. He proposed that these ostium atherosclerotic plaques were actually responsible for decreased perfusion of the ophthalmic artery. And these plaques at the ostium of the ophthalmic artery, lo and behold, would be responsible for decreased ocular perfusion. So all this data was out there, and I have to give Ocudyne and our collaboration the ability to pull all this data together, and that resulted in a study at the Massachusetts General Hospital Martino Center, where we took patients with early, intermediate, and late AMD, as well as controls that were referred by Jeff Heyer and Nadia Waheed, and we imaged them using 7 Tesla MRI MRA. And we showed, and this work has been published, we showed that lo and behold, there was decreased ophthalmic artery perfusion with worsening stage of age-related macular degeneration. This was done without contrast, just using MRI, MRA imaging, and a 64-channel head coil. And I'm pleased to report that there is a study that just got published from Randy Carden's group in Iowa, looking at laser speckle fluorography, which is going to be our in-clinic modality moving forward to measure choroidal blood flow. And he just published this paper in AJO showing that laser speckle fluorography also demonstrates decreased choroidal perfusion with increased severity of AMD. So there's just a body of literature now that provided the background that now has led up to the Ocudyne study in Buenos Aires.
Oh,
okay, so shall
connect
we
connect the dots?
Yeah. So this is how we connected the dots in Buenos Aires. We wanted to get a study going in the United States, but the FDA device section said, no. We can't put Americans at risk doing this study, which involves a specialized catheter balloon angioplasty device for the ophthalmic artery. We can't put Americans at risk. You got to go overseas to what are called those tier 1 countries. And we started working in Australia, and the study was up and going, and the first patient was being screened, and then COVID shut down the entire country of Australia. So then we had to pivot, and we pivoted to Buenos Aires, and Pedro Lilich, who's a world-renowned interventional neuroradiologist, and Mario Saravia, who's a phenomenal retina specialist and clinical trialist, and we got this study started in Buenos Aires. And this study was a safety study. It was a feasibility study. And I always emphasize, whenever we're doing a phase 1 drug study or a feasibility study, the study is for safety. But of course you want to look at efficacy, but I have to keep reminding my colleagues, these studies, these phase 1, these feasibility studies are safety studies. So Ocudyne came up with their microballoon catheter and their aiming microcatheter. And lo and behold, they started this study in Buenos Aires, in which both Mario, as the retina specialist, screened patients, and the interventional neuroradiologist screened patients. And they found patients with advanced geographic atrophy who were willing to participate in this feasibility study. And the patients were treated on day 0, and then followed for 6 months, 3 months by the interventional neuroradiologist and the retina specialist, and then an additional 3 months by the retina specialist. And lo and behold, they could enroll up to 20 subjects, but 17 were enrolled because of the time delay in getting the study started. The device's shelf life expired. So rather than go through the whole approval process for the devices, they stopped at 17. 6 of those 17 were excluded from the study because they could not be cannulated in the ophthalmic artery. So for interventional neuroradiologists who are willing to cannulate anything, they found certain patients to be a challenge, and that's why we're revising the catheter, and it's going to be developed specifically for the ophthalmic artery, which has some unique properties compared to other intracranial arteries. And they were able to study 11 patients with an average baseline visual acuity of 2320. That's what got into the study. And there were no serious adverse treatment effects. Lo and behold, when you followed these patients for 6 months, the average visual acuity improved 6.7 letters, and it was sustained after week 4, while the fellow eye showed gradual decrease in visual acuity. And this was true for normal luminance visual acuity as well as low luminance visual acuity. And when we looked at changes in the eye, adverse events, there were 5 cases of adverse events, none of them serious, none of them causing any vision loss. There were 4 cases of microemboli that caused little cotton wool spots outside of the central macula, and all dissipated within a week or 2. And there was 1 flame-shaped hemorrhage that occurred, again, outside the macula, that dissipated with any loss of visual acuity. Now, fluorescein angiography or OCT angiography was not part of the study. We're going to be including it moving forward. So we didn't know the full extent of any focal ischemia that may have resulted. But these were observations that did not affect vision and would not have been detected if the patient had been reporting any changes. They were all observed on fundus imaging and on exam. So when you look at the totality of the data, the success rate increased as the study progressed. More than 50% of patients gained at least 1 line of vision. And using all the latest flow metrics that you can use based on MRA imaging, increased perfusion of the ophthalmic artery was detected, and increased perfusion around the globe was detected. Much like the choroidal flush you see when you inject contrast agent in the ophthalmic artery, we see this increased choroidal flush just using magnetic resonance angiographic imaging. And there were certain patients that did exceptionally well as a result of this treatment. And as in the field of genetics, I've learned you always want to treasure the exception. These patients are telling us something very important in the role of ocular perfusion in age-related macular degeneration.
So what's the next step?
Well, we want to open a feasibility study in the United States, and the Argentinian government is very interested in us moving forward with a pivotal study in Buenos Aires. So our priority is to get a feasibility study going in the United States. Our priority is to revise the microcatheter guide wire and balloon angioplasty device so that it's even better in manipulating and maneuvering within the ophthalmic artery. So those are ongoing. Discussions with the FDA are ongoing. And the FDA had a very simple request. They wanted a cross-sectional analysis. You take 25 patients with geographic atrophy and 25 patients with wet macular degeneration. What is the likelihood that these patients would have ophthalmic artery stenosis? Well, we wanted to work out our ability to image the ophthalmic artery using clinical devices, not experimental 7 Tesla MRI like we did at the Martino Center. So I have to acknowledge the fabulous work that Omer Travisky has done in Tel Aviv with his radiologists. But they embraced the challenge, and using a 3 Tesla commercially available MRI MRA with a 64-channel head coil, they've worked out a protocol to image the ophthalmic artery without any use of contrast. That was our requirement at the Martino Center, and we placed the same requirement on Tel Aviv. And sure enough, they have a protocol that reliably images the ophthalmic artery with this head coil without the use of any contrast agent. So they looked at these 50 patients, 25 with geographic atrophy and 25 with wet AMD. And they found that more than 30% stenosis was identified in about 90% of those patients. So stenoses are not rare. Stenoses of the ophthalmic artery are common. And the way we think about the disease now, we don't think that ophthalmic artery stenoses cause macular degeneration. We think it happens with normal aging. And there's an independent study out of Australia that looked at digital subtraction angiography, CT, looking at people. And they found by the age of mid-50s that over 15% of patients have some kind of ophthalmic artery stenosis. So this is not rare. This happens as part of aging. But if you have the genetic risk alleles for AMD and you have ophthalmic artery stenosis, I think this was the missing link that put together why some patients progress at an earlier age, why some patients with AMD progress faster than other patients, why some patients need more anti-VEGF therapy than other patients. And one of the questions we had is, does the growth rate of geographic atrophy, is it associated with the extent of the ophthalmic artery stenosis? So here's another interesting observation that came out of the Tel Aviv study. If you look at the area of GA, just the area of GA in the 25 patients that were investigated, there is a significant correlation between the area of GA and the extent of the ophthalmic artery stenosis. That was totally unexpected. And I think the only way that makes sense is if the ophthalmic artery stenoses contribute to the growth rate of GA. So that's a study that's ongoing. We hope to have the results soon. So I think we've got a genetic disease that comes on later in life. And one of the most important environmental factors that has been overlooked up to this point is the extent of ocular perfusion. And that's going to be influenced by the stenoses in the ophthalmic artery.
What's the mechanism of visual improvement?
That's a fascinating question. Again, an unexpected outcome. And we were originally very skeptical that it was real, but it persisted. And talking to the patients, they clearly reported shortly after awakening in the OR and coming out from the procedure that they were seeing brighter colors, were more vibrant. So this concept of dormant photoreceptors has been discussed for quite a while. And it's been shown in animal studies that photoreceptors can go dormant. They lose their outer segments, but then with appropriate stimuli, and I think Joe Carroll deserves credit for looking at the hibernating ground squirrel, and he's shown that while they're hibernating, they lose their outer segments, but lo and behold, they come out of hibernation and the outer segments regenerate. Could a similar concept be applied to photoreceptors in the retina that are operating suboptimally? They haven't died, they're still there, but perhaps they're not functioning because they're hypoxic. And you increase the perfusion, and suddenly those photoreceptors, I'm not going to say regenerate, but the photoreceptors now are functioning at a higher level. So If this can happen with patients with geographic atrophy, and as we all know, around the geographic atrophy, a number of groups have reported this, including us, and now we have microperimetry data to support it from the Apellis studies, that there's decreased light sensitivity around the geographic atrophy. We know from OCT structural studies that the outer segments, the ellipsoid zone, those regions around the GA, the photoreceptors are abnormal. Now, we've never demonstrated resurgence, reactivation of photoreceptors. This has never been shown in humans, dormant photoreceptors. They do occur in animals, but perhaps this region around the GA that isn't functioning optimally can suddenly recover visual function capabilities. Who knows? But it's very exciting. And I think this concept of reperfusing the eye can be applied to not only dry macular degeneration, but wet. And it's so obvious in wet. Why are some patients requiring so much anti-VEGF therapy compared to other patients? It's an ischemia-driven disease. You're treating VEGF. Why is the VEGF being produced? Everyone just waves their hands and says, well, the local environment is conducive to VEGF production. Well, it has to be ischemia-driven. Inflammation? Perhaps. So I'm very excited about the future for reperfusing the eye. And this is one way to do it. There's another company called Perfusion Therapeutics that did a very interesting study recently where they used this anti-endothelin peptide that blocks the endothelin receptor. And lo and behold, endothelin causes vasoconstriction. And this therapy, this receptor antagonist, increases perfusion of the retinal circulation. And they've studied it now in glaucoma and diabetes. And we'll see at angiogenesis, they're going to show the results, at least for diabetes. And the preliminary results look like it really improves the clinical progression of glaucoma and diabetes. So if just dilating retinal vessels increases perfusion, imagine increasing the whole perfusion to the eye and dilating vessels. There could be quite the synergistic effect here. So I think we're entering a new age of therapy for the eye. The perfusion model, I think, will turn out to be very valuable, not only for age-related macular degeneration, but perhaps diabetes, particularly glaucoma, normal tension glaucoma. And what about anterior ischemic optic neuropathy? Wouldn't this be a great treatment for something that's untreatable, the non-arteritic ischemic optic neuropathy?
That was fantastic. A whole new spectrum.
Absolutely.
What's the timeline for the preliminary trial, do you think?
We hope to get the Buenos Aires pivotal study up and going in 2026 once we get finalized the device improvement, and that's ongoing now. And we're hoping, we just submitted a package to the FDA, we're hoping to get approval for a feasibility study in the United States. But what's so nice about being in Florida, my patients are ready to jump on a plane and fly to Buenos Aires because you fly directly south, it's really convenient, and if necessary, we'll have to start treating patients in Buenos Aires. But I think for patients with the requirement of repeated anti-VEGF therapy and for patients with geographic atrophy growing, and I treat them with Syfovre, I'm a Syfovre believer, but we're just slowing down the progression of geographic atrophy. Wouldn't it be nice to combine Syfovre with improvement in ophthalmic artery perfusion? You know, we all love anecdotal cases. And I have a patient that I just saw last week where in 2017, He had bad wet macular degeneration in one eye, required large scar that hemorrhaged, and he required frequent anti-VEGF. In the other eye, he had intermediate AMD, which raises the whole question: is why is there this asymmetry between eyes? Right? No one really talks about that. We're now publishing in this concept of asymmetry, asymmetry in disease progression, asymmetry in response to Syfovre. Something to think about. We're going to be reporting on that at ARVO. So he undergoes, this patient, bilateral carotid artery stent placement, all right? And after that procedure in 2017, he's part of my natural history study, and I see him every 3 months. As a result of bilateral carotid artery stent placement, he hasn't needed another anti-VEGF injection, and 90% of the drusen in the eye with intermediate AMD went away. I might add that in the 6, 7 years since the procedure, the drusen are slowly coming back. Intriguing. And he actually flew over to Tel Aviv, and they identified a 40% stenosis in his ophthalmic artery. So he's ready. He wants to be first in line to undergo this balloon angioplasty, his ophthalmic artery. He's clearly a vasculopath. He has stents in his heart. He has stents in his carotid. He's on medication, but he's very active and functioning, and he's desperate to preserve whatever vision he can.
Well, this is exciting. Well, stay tuned, Phil. Thank you for sharing this news. That's really a blast from the past.
Indeed, ideas can recirculate. And what I love is taking the observations that have been made decades ago and connecting the dots and making it a treatment paradigm that just makes sense based on what we've been doing in our research and what other people are doing in their research.
Thank you, Phil.